a CJSON podcast, and I am Fernando Fervenza, along with Marta Casal Moura and Ulrich Specks from the Mayo Clinic, and we'll be presenting our paper recently published in the journal. ANCA-associated vasculitis are remitting relapsing diseases with relapse expected to occur in 30 to 50% of the patients. The risk of relapse has been clearly established for patients with PR3 ANCA. However, little information is available regarding the risks of relapse in patients with Myeloperoxidase MPO Antineutrophil cytoplasmic antibodies presenting with kidney involvement. The main goal of remission maintenance treatment are prevention of relapse while avoiding long-term drug toxicity and comorbidities. As such, it is important to determine which patient needs maintenance immunosuppression, the optimal duration of therapy, and whether withdrawal of remission maintenance is possible without increasing the relapse risk. The decision to withdraw remission maintenance treatment is complicated by the absence of high-quality data and specific guidance criteria.
To characterize the relationship of relapses to MPO-ANCA status and remission maintenance treatment, we conducted a retrospective cohort study of MPO-ANCA positive patients with AAV and glomerulonephritis. Patients were longitudinally analyzed and classified into three categories according to their MPO-ANCA status at the end of the follow-up. 1, sustained seronegative patients that turn MPO-ANCA negative at any time during follow-up and remain negative. The second was reappearance patients that turn MPO-ANCA positive after becoming MPO-ANCA negative. And the third category was persistently positive patients who remain MPO-ANCA positive throughout the follow-up. The MPO-ANCA status at the time of remission was also recorded, and the serial determinations at all available time points were also recorded. We analyzed 159 patients with active MPO-ANCA-associated vasculitis with glomerulonephritis. 42% of the patients had at least one relapse, and a total of 33% relapsed before 60 months. Patients with MPO-ANCA who become persistently negative did not relapse. The reappearance of MPO-ANCA was associated with a higher risk of relapse. Immunosuppression was withdrawn in about half of the patients, and this was less likely in those who received cyclophosphamide for remission induction or in patients with persistently MPO-ANCA positive. Relapse frequency was not different between patients with persistently positive MPO-ANCA and patients with MPO-ANCA reappearance irrespective of remission maintenance treatment. Here, nose and throat involvement and MPO-ANCA reappearance were independently associated with relapse after treatment withdrawal.
In conclusion, patients who turned and remained MPO-ANCA negative were not at risk for relapse. However, subsequent MPO-ANCA reappearance was a major risk factor for relapse. Patients with persistently positive MPO-ANCA were at risk for relapse even under continued remission maintenance immunosuppression with standard disease-modifying drugs. Thus, remission maintenance therapy may be discontinued in patients who remain MPO-ANCA negative without a higher risk of relapse, avoiding unnecessary exposure to immunosuppression. Consequently, serial monitoring of MPO-ANCA status during clinical remission may contribute to the clinical decision-making about remission maintenance treatment.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.